Have you ever seen a pair of X-ray specs? They used to sell them in the back pages of comic books. And for a couple of dollars, shipping included, you'd get them. You'd put them on and supposedly you were able to see through walls, see through skin, see through clothing, and see the bones inside of a body. Of course, they didn't actually work. They were a toy, a joke, a trick. A cardboard frame with two little feather discs inside, bird feathers. The barbs acted like a tiny diffraction grating, splitting light into overlapping images. Your brain filled in the rest. You thought you were seeing something hidden, but you were really just seeing an optical illusion. When I was a child, I wanted a pair badly. My parents talked me out of it. They knew what I didn't, that it was just an illusion. You'd put them on and you'd see exactly what you wanted to see, not what was actually there. But here's the thing. I grew up and became a diagnostic radiologist, and I've spent 42 years doing for real what those glasses only pretended to do, seeing the invisible. Every day, bones, soft tissue, pathology, hiding beneath the surface of the skin. Things that are absolutely there, but that you cannot see without the right tool. And that's what's funny about those X-ray specs. The principle behind them, using a feather to split light into its hidden components, actually goes back to a Scottish mathematician named James Gregory in 1673. He held a bird feather up to a beam of sunlight and watched it separate into a spectrum of colors. He had no idea what was causing it, but he was seeing something real that no one else could see. The X-ray specs were a trick. Gregory's feather was a diagnostic tool. And as a radiologist, I can tell you, the difference between seeing an illusion and seeing what's actually there is everything. That's what this episode is about.
Welcome to the Doctor's Mentor Show. If the right to practice medicine without interference is important, and you want expert tips for practice freedom and profits to support your epic life, welcome aboard and prepare to be blown away. The Doctor's Mentor Show starts now. Here's your host, Dr. Lori Barr.
Because right now, you're running your practice without the diagnostic tool you need. You're looking at your revenue and you think you're seeing the full picture, but there's a spectrum hiding inside those numbers. There might be $75,000 to $200,000 a year in revenue that you're not capturing, and you can't see it. Not because you're not smart enough, but because no one's ever handed you the right lens. Let me tell you about a physician I spoke with recently. I'm going to call him Dr. Frank. Dr. Frank has been in practice for over 30 years, primary care, sole owner. He's treated thousands of patients, built a reputation in his community, and earned the respect of his colleagues. And when I asked him how things were going, he said something I haven't been able to stop thinking about. He told me that primary care wasn't always his main revenue source. For years, he had a cash pay specialty component, occupational medicine, direct contracts, services that paid well and didn't require a prior authorization fight. That part of the practice accounted for 70% of his income. Then the market shifted. Equity firms moved in. His cash pay revenue collapsed during COVID. And now, 3 decades into his career, he's doing 90% insurance-based primary care at $60 to $70 per follow-up visit. He said 2 words that I think you'll recognize and maybe resonate with. He said, "It hurts." Not "it's frustrating," and not "it's challenging." It hurts. Because he's doing the math every day. He knows what the insurance companies pay themselves, 2 to 3 times what they pay him. He knows that as a non-procedural physician, the revenue per visit is structurally low. And he knows that the business model he's currently running requires him to see more and more patients just to keep the lights on. Dr. Frank isn't failing. His revenue problem is invisible. It's not on the surface. It's structural. hiding inside the way he's built the practice, inside the pricing he accepted years ago and never revisited, inside the patients who left and were never reactivated, inside the referral relationships he never systematized. In this episode, we're going to make that invisible revenue visible. We're going to walk through the 7 revenue levers that exist inside every independent practice, and I'm going to show you how to diagnose the 2 or 3 that are costing you the most money right now. Because the number, based on what I've seen across 25 years of practice ownership and hundreds of conversations with practitioners, is between $75,000 and $200,000 a year. That's not aspirational. That's structural. It's already there. You just can't see it. Stay with me. In our last episodes, we explored the art of strategic disengagement, knowing what to stop doing, and the power of community to break the isolation of solo practice ownership. Today, we're going somewhere that makes most practitioners uncomfortable. We're talking about money, not in the abstract, not revenue cycle management best practices, not a lecture on RVUs and payer contracts. We're talking about the specific, identifiable revenue that is hiding inside your practice right now. Revenue you're not capturing, not because you're incompetent, but because no one ever taught you where to look. Here's what I've noticed in virtually every conversation I have with independent practice owners. You know something is off. You can feel it. The numbers don't match the effort. You're working harder than you were 5 years ago, and your take-home hasn't changed, or it's gone down. But when I ask you to tell me where the gap is, you can't. Not precisely. You might say things like, insurance reimbursements have gone down. Or, I'm throwing money at marketing, but it's not working. Or, and this one comes up more often than you'd think, I feel like I've shortchanged myself in terms of what I've made. That last phrase stopped me cold the first time I heard it, because it came from one of the most credentialed, most published, most nationally recognized physicians I've ever spoken with. Someone whose expertise has literally shaped international clinical standards. And she used the word shortchanged. Not underpaid by an employer. Shortchanged, as in she participated in her own undervaluation without realizing it. That's the money blind spot I want to talk about today. It's not that you're bad at business. You might be extraordinarily sophisticated. I've spoken with owners running multi-million-dollar operations. I've spoken with physicians who hold MBAs from top programs. The blind spot isn't intelligence. It's proximity. When you're inside the practice, seeing patients, managing staff, fighting insurance companies, keeping the lights on, you can't see the structural patterns that are costing you money. You're too close. It's like being inside a building and trying to read the address on the front door. You need distance. You need a diagnostic framework that forces you to look at your practice the way a strategic consultant would, from the outside in. That's what we built, and that's what I'm going to walk you through today. Over the 25 years of owning my own practice, and after working with hundreds of independent healthcare practitioners, I've identified 7 revenue levers that exist inside every practice. Not some practices, every practice. These 7 levers account for the gap between what you're currently earning and what your practice is structurally capable of producing. And in my experience, most practice owners are only actively managing 2 or 3 of them, which means 4 or 5 levers are just sitting there untouched, quietly costing them money every month. Let me name all 7. Then we're going to go deep on 2 of them, the 2 I find that are most commonly neglected and are most immediately actionable. Lever 1 is price optimization. Are you charging what your market will bear for your level of expertise? Or are you still using fee schedules you set 5 years ago? Or worse, fee schedules someone else set for you? Lever 2, service mix. What's the ratio of low-margin services to high-margin services in your practice? Are you over-delivering the things that barely cover overhead and under-delivering the things that actually drive profit? Lever 3, conversion rate. When a patient comes in for a consultation, what percentage convert to treatment? And what is that gap costing you annually? Lever 4, Patient lifetime value. Are your patients getting the full continuum of care you're capable of providing, or are they dropping off after the initial visit and you never follow up? Lever 5, patient volume strategy. Should you be focusing on higher volume, higher value, or a specific mix of both? And does your current volume match your capacity and your market? Lever 6, reactivation potential. How many inactive patients are sitting in your records right now? People you saw once or twice, had a good experience, and just drifted away. What would it be worth to bring even 10% of them back? Lever 7, referral velocity. How many of your best patients, the one you love, who tell their friends about you at dinner, are actually referring? Not theoretically, actually. And what would happen if you made it easy and systematic for them to do so? 7 levers. Your practice has all 7. When you think about revenue growth, you probably default to 1 or 2 strategies. See more patients or renegotiate insurance contracts. Those are valid strategies, but they're the hardest strategies. They require the most effort, the most time, and the most external cooperation. The 7 levers I just described, most of them are internal. They're things you control. And several of them can be optimized in 30 days without hiring a single new person or adding a single new patient. That's the insight that changes everything. You don't necessarily need more patients. You need to stop leaving money on the table with the patients and the pricing and the systems you already have. Let's go deeper on the first lever, price optimization. I want to tell you about another practitioner I spoke with. I'll call her Dr. K. Dr. K is early in her ownership journey, about 5 years in. She bought an existing practice, and in her words, she was, I'm quoting loosely here, up to her eyeballs in debt between student loans, a business loan, and equipment loans. When I asked her what she was charging, the answer told me everything I needed to know. She was using the fee schedule that came with the practice owner's pricing who had previously owned the practice. She hadn't changed it, not once in 5 years. And when I asked her why, she said something I hear constantly. I still don't really know what I'm doing for the business side. I've never been taught it. Here's the thing. Dr. K is not unusual. She's the norm. The vast majority of physicians report receiving little to no business or financial training during medical school or residency. And a few practice owners regularly review and adjust their fee schedules, even when their costs have increased. Now think about that. Your rent goes up, your staff wants raises, your supply costs increase, your malpractice premiums increase, but your prices, those stay the same. In what other business would that be acceptable? In what other industry would a professional with a decade of training and a doctoral degree charge the same price year after year while every input cost rises? Here's what I want you to do. And you can do this today, before this episode is over. Pull up your top 10 most performed services. Look at what you're charging. Then look at what the market will bear. For cash pay services, this is relatively straightforward. What are practitioners in your area at your experience level charging for the same service? If you're below the median, you have a pricing gap. And I'm not talking about being the most expensive. I'm talking about being appropriately priced for your expertise. For insurance-based services, you have less control, but you have more control than most people think. Your contracted rates are negotiable. When was the last time you renegotiated? If the answer is when I signed the original contract, you likely have a gap. But here's the pricing lever most people miss entirely, your non-insurance revenue. I spoke with a physician who told me that his insurance payments are going down every year, and I'm paraphrasing. You have to pull your hair to get a couple of dollars. Meanwhile, his rent went up 50%. His staffing costs are rising. His response? work harder, see more patients, run faster on the hamster wheel. But when we looked at his practice, there were cash pay services he could be offering, wellness programs, specialized consultations, telehealth packages that would diversify his revenue away from the declining insurance model. Services where he sets the price, services where there's no prior authorization, no billing department, no 90-day wait for payment. He wasn't ignoring these opportunities because he didn't want to do them. He was ignoring them because he couldn't see them. He was so deep inside the insurance model that he forgot there were other ways to generate revenue. That's price optimization, not just charge more, though that's often part of it. It's charge appropriately, diversify your revenue sources, and stop accepting a fee structure designed by someone else to benefit someone else. Now let's look at the lever I find most consistently overlooked and frankly the easiest to activate. That's lever 6, reactivation potential. Let me ask you a question. Right now, how many patients are in your practice management system who haven't been seen in 12 months or more? If you're like most independent practice owners I talk to, you don't know the exact number. But I can tell you it's significant. If your practice has been open 5 years or more, it's typically hundreds. If you've been open 20 years, it could be thousands. These are people who found you, who chose you, who had an experience with you, probably a good one, and then they drifted. Not because they were unhappy, not because they found someone better. They just stopped scheduling. Life got busy. They moved across town, but not out of the area. They had a baby. They switched insurance and assumed you didn't take the new plan. They meant to come back and just forgot. These patients are golden, and they're sitting in your records doing nothing. Here's the math that will make this real. Let's say you have 500 inactive patients, people you haven't seen within 12 to 24 months. That's a conservative number for most established practices. If you run a systematic reactivation campaign, not a blast email, not a generic postcard, but a thoughtful, personalized outreach sequence, you can typically reactivate 10 to 15% of them. That's 50 to 75 patients coming back in for visits they weren't going to schedule. If each of those patients generate even $300 in revenue over the next 12 months, and that's conservative for most specialties, you've just generated $15,000 to $20,000 in revenue from people who were already your patients without spending a dime on advertising and without competing with anyone. Now scale that. If you have 1,000 inactive patients, which many established practices do, and you reactivate 10% at an average of $500 per patient per year, that's $50,000 from your existing patient base from a system you build once and then run quarterly. I spoke with a practice owner who told me he was spending $5,000 a month on marketing, $60,000 a year, and he couldn't tell if anything was working. Meanwhile, he had years of patient records sitting in his system, real people, real relationships, real clinical history, zero systematic outreach. He was spending $60,000 a year trying to find new patients while ignoring the patients who already knew him and trusted him. That's the reactivation lever. It's not glamorous. It's not cutting edge. It doesn't involve AI or a social media strategy. It involves looking at the people who've already chosen you and asking, would they come back if I reached out? The answer overwhelmingly is yes. Here's what I'd encourage you to do this week. Ask your front desk or your practice manager to run a report of patients who haven't been seen in 12 months or more. Just get the number. Don't do anything with it yet. Just look at it. Because that number represents latent revenue. Revenue your practice has already earned the right to capture, and it's waiting for you to notice it. So if these levers are real, and they are, why don't more practice owners see them? I've thought about this a lot, and I think the answer comes back to something I mentioned earlier. Proximity. When you're inside the practice, you're in survival mode. You're solving today's problems. The patient who's waiting, the staff member who called in sick, the insurance denial that needs to be appealed, the vendor who raised their prices. You're reacting. And reactive mode has a very specific cognitive signature. It narrows your field of vision. There's a concept in psychology called attention narrowing. When you're under stress, your brain literally restricts what you can perceive. It's an evolutionary adaptation. When a threat is present, your brain filters out everything that isn't immediately relevant to survival. For a practice owner under financial pressure, that means you can see the declining reimbursement check. You can see the payroll due on Friday. You can see the marketing invoice. What you can't see, because your brain has filtered it out, is the structural pattern underneath. The pricing you haven't updated, the patients you haven't reactivated, the referral system you never built, the service mix that's tilted toward your lowest margin offerings. That's why in almost every conversation I have with a practice owner, there's a moment when they say something like, I'm throwing money at everything I can think of, but it's not growing. And they're not wrong. They are throwing money, but they're throwing it at the visible problems, advertising, consultants, new equipment, more staff, while the invisible problems, the 7 levers, go unaddressed. And here's the part that's hardest to hear. The longer you've been in practice, the harder that is to see on your own, because the patterns have calcified. Your pricing, your service mix, your patient flow, they feel normal. They feel like just the way it is. But that's not the way it is. That's the way you built it years ago under different circumstances with different information, and they can be rebuilt. That's what a diagnostic framework does. It forces you to look at your practice with fresh eyes, not through the lens of today's emergency, but through the lens of structural opportunity. Now, here's where this gets really powerful, and this is the part that surprises people most. I've been talking about individual levers as if they operate independently. They don't. Revenue levers compound. When you optimize your pricing and improve your service mix so you're charging appropriately for higher margin services, the impact isn't additive. It's multiplicative. When you reactivate dormant patients and improve your referral velocity, so those reactivation patients are also referring, you've created a flywheel, not a one-time bump. Let me give you a real-world example. Imagine a practice doing $800,000 in annual revenue. The owner feels stuck, that hamster wheel feeling that so many practice owners describe. Now imagine that owner makes 3 changes. First, she adjusts her fee schedule, not dramatically, just bringing it up to market rate. That's a 5 to 8% increase on the services she controls. On $800,000, that's $40,000 to $64,000. Second, she runs a quarterly reactivation campaign. Over 12 months, she brings back 75 patients who generate an average of $400 each. That's $30,000. Third, she introduces one systematic referral program. Not complicated, just a simple thank you for referring process that makes it easy for satisfied patients to send their friends. That generates 20 new patients at an average lifetime value of $800. That's $16,000 in year 1. Add those up, $40,000 plus $30,000 plus $16,000. That's $86,000 in additional annual revenue from 3 changes, none of which required her to see a single additional patient per day, none of which required her to hire somebody new, none of which required a new marketing budget. And in year 2, the pricing adjustment is permanent. The reactivated patients are now in the regular flow. The referral system is generating new patients every month without additional spend. The compound effect of optimizing even 3 of the 7 levers can transform a practice's financial trajectory within 12 months. That is what I mean when I say there's $75,000 to $200,000 hiding inside your practice. It's not a guess. It's the compound math of structural optimization across levers you're currently not touching.
Your next step.
So what do you do with this? I want to give you 3 options because the right one depends on where you are and how you like to work. Option 1, run your own revenue velocity audit. You don't need my permission or my framework to do this. Here's a simplified version you can start this week. Step 1. Pull your top 10 services by volume. For each one, ask, when was the last time I reviewed this price? Is it at, above, or below the market rate? Step 2. Run an inactive patient report. How many patients haven't been seen in 12 months or more? Pick 20 and have someone call them personally, not a robocall, a human being saying, we noticed it's been a while since your last visit. We'd love to see you again. Step 3. Ask yourself this question of the patients I saw this month. How many received the full scope of care I'm capable of providing? Not upselling, genuine clinical care that helps them. The follow-up imaging, the preventative screening, the specialist referral, the wellness conversation. If patients are leaving your office having received less than what they need, that's a patient lifetime value gap, and it's costing you money while also underserving your patient. Those 3 steps, pricing review, reactivation outreach, and lifetime value assessment, will give you a rough estimate of the revenue you're currently leaving uncaptured. It won't be precise, you won't have benchmark data, but it will open your eyes. And that's the first step. Option 2, the Practice Growth Launchpad, our 2-week virtual implementation sprint. If you want the full diagnostic, but you can't travel to an in-person event, or you just work better from your own office, this is built for you. The Launchpad is a live virtual 2-week sprint. You'll work through both the revenue velocity diagnostic and the practice flow audit using real numbers from your own practice with me and a small group of other independent practice owners doing the same work alongside you. Here's how it works. Each week has 3 touch points. You start the week with a 90-minute framework training session. That's where we walk through the methodology and you apply it to your practice in real time. Midweek, there's a co-working check-in for troubleshooting and implementation support. And the week closes with a mastermind experience, peer interaction, collaborative problem solving, the kind of thinking that's impossible to do alone. By the end of the 2 weeks, you walk away with 3 completed assessments, a personalized practice growth blueprint, a practice flow audit with a 30-day workflow optimization roadmap, and a scored revenue velocity diagnostic with a 90-day revenue acceleration plan. You also get industry benchmark comparisons, templates you can reuse, and recordings of every session. The Launchpad investment is less than what you charge for a fluoroscopic exam like an upper GI. If you complete it and you don't feel you received that value, we'll refund your money, no questions, part friends. And if you decide to join the full Practice Growth Mastermind, my year-long program, your Launchpad investment is credited toward your membership. Head to thedoctorsmentor.com/practice-growth-launchpad to learn more and apply. Option 3, Discovery Day, our in-person hands-on diagnostic experience. If you want to do this work in a room face-to-face with me and a small cohort, that's Discovery Day. It's the first day of our quarterly Practice Growth Mastermind implementation getaway. During Discovery Day, you'll complete the full revenue velocity diagnostic and the practice flow audit. Same frameworks as the Launchpad, plus 2 additional frameworks. The Congruence Catalyst method for team alignment, and Make Up Your Mastermind, an AI-augmented advisory board methodology. You'll leave with a revenue velocity map, a 1-page visual roadmap showing your fastest path to 50 to 150,000 in additional annual revenue, plus a 90-day action plan with specific monthly targets with decision checkpoints. Discovery Day is the same investment, less than a single fluoroscopic exam, fully refundable and fully credited toward Mastermind membership. Head to thedoctorsmentor.com/Discovery Day to learn more and apply. Here's what I want you to hear. Regardless of which option fits you best, the most important thing is that you start looking because the revenue is there. It's been there. And the only reason you haven't captured it is that no one showed you where to look. Now you know. Before we close, I want to say something directly to you if you resonated with Dr. Frank's story at the top of this episode. If you've been doing the math and the math hurts, If you know in your bones that you're working too hard for what you're earning, that's not a personal failing. You were trained to take care of patients. You were brilliant at learning that. And then you were handed a business with no training manual and told to figure it out. And you did figure it out to a point. You kept the doors open. You made payroll. You served your community. But keeping the doors open and building a practice that reflects the full value of your expertise are two very different things. The first one requires survival skills. The second one requires strategic vision. And strategic vision is hard to develop when you're inside the building, reacting to emergencies, running on a hamster wheel that someone else designed. The 7 levers are real. The money is real, and your ability to capture it, once you can see it, is absolutely within your reach. You've already done the hard part. You built the practice. You earned the patient's trust. You developed the clinical expertise. Now it's time to build the business that honors all of that. I'm Dr. Lori Barr. I'll see you in the next episode of the Doctor's Mentor Show. Remember, one idea is all it takes to change your world.
You're listening to The Doctor's Mentor, hosted by Dr. Lori Lee Barr. Podcast content is provided for informational purposes only and is not intended for the purposes of curing, diagnosing, preventing, or treating any disease or medical condition. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare, legal, or accounting professional. If you suspect you have a medical problem or you should have any healthcare questions, please promptly call or see your healthcare provider. Carefully read all labels and heed all directions and cautions that accompany products or services. Before using any strategies, activities, or products referenced in this podcast, consult with your lawyer, accountant, or medical professional. The Doctor's Mentor was created by Dr. Lori Lee Barr. It is owned by Peak Idea, LLC, executive producer, Dr. Stephen Dent, audio-video engineer, Richard Dent. The company, Dr. Lori Lee Barr, and the producers disclaim responsibility for any possible adverse effects from the use of information contained herein. This podcast does not make any representations or warranties about the qualifications or credibility of guests. Opinions of Dr. Lori Lee Barr are her own. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast may contain paid endorsements or advertisements from products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services mentioned. Remember, one idea is all it takes to change your world.
There's more to explore at thedoctorsmentor.com.